All right, well, good afternoon, and thank you for, well, first of all, Happy New Year to everybody, and thank you for coming to our first event of 2018 for the HIMSS Foundation's Institute for eHealth Policy. It's my pleasure to be the executive director of the HIMSS Foundation in addition to my other duties as the Vice President of Government Relations for HIMSS. So we've got a great conversation today around interoperability with some real specifics around DoD and VA interoperability, and then of course the national and international scope with our distinguished colleague from the Office of the National Coordinator. So I wanted to start off by thanking Chairman Rowe and his staff for serving as an honorary co-host for this event today. And specifically around as far as staff, Kim Osborne, a former HIMSS intern many years ago, now a great staffer for the Veterans Affairs Committee, and Matt Kessler for their help in getting today going. But as far as jumping right into the agenda for today, we're very fortunate to have three fantastic speakers to talk from the DoD, the VA, and the Office of the National Coordinator perspective. We have staff from the DoD VA Joint Program Office available for the Q&A. Our longtime friend, Dr. Lauren Thompson, sends her regards with a challenge this morning. A scheduling challenge has kept her away, but she'll be back for the next set of education sessions. So for that, let me invite our three panelists to come on up. Dr. Paul Cordts is the director of the Functional Champion for the Military Health System. Dr. Ash Zenooz, the Chief Medical Officer for the VA EHR Modernization Program Executive Office, and of course, Ms. Genevieve Morris, the Principal Deputy National Coordinator for Health IT. The way we really like for these sessions to go is we'll have some opening remarks from each of the panelists, and I've got a few questions that I've got teed up, but it's really about the beauty of our Institute events is the dialogue and the challenge and the opportunity for you as an audience member to ask and be involved in the discussion. So get your thoughts going and your questions ready, as this will be an interactive hour and 20 minutes. So with that, Dr. Cordts, you're welcome to come on up here or be right there, either way. But you might want to stay there. Just watch out for this boy. Yeah.
Very good. Okay, that sounds good. Thank you very much. And thank you, Tom, and good afternoon, and thanks everybody here for coming. We appreciate the invitation. So just a few remarks here, kind of opening remarks. I'm the Military Health System Functional Champion. So people ask me, okay, what does that mean exactly? I represent the functional communities, clinical, business, and operational communities throughout the agency, specifically right now with respect to deployment of our new electronic health record, MHS Genesis. I'm a vascular surgeon. I've commanded 2 Army hospitals, retired about 3 years ago, and so I'll just give the frame and kind of the way we're thinking about interoperability here first. And we're thinking of it in 3 major buckets. The first is interoperability between medical devices, and that's inside our hospitals and our clinic. A specific use case is the intensive care unit. Do the devices talk to each other within the intensive care unit? The second bucket would be interoperability of clinical data. More than 50% of our care is delivered in the TRICARE network or outside the military healthcare system, and so, or in the VA. And so it's important that our providers can see the data about the care delivered outside the gate, that is in the TRICARE network and the VA, and vice versa. Providers caring for our patients in the TRICARE network or the VA can see data about the care we've rendered in our military hospitals. And thirdly, interoperability of clinical data between the garrison, what we call the garrison environment, which is back home and in the operational theater like Iraq or Afghanistan, something like that. So I just want to step through those briefly here. The interoperability of medical devices, the ICU kind of as the use case. You've got a ventilator, an arterial line, a Swan-Ganz catheter, alarms, and so a lot of sort of technical wizardry going on. But really, most often, it requires a human, a doctor, a nurse, to synthesize those data or integrate that data in their minds from multiple devices and then decide what the next step will be. So, and this is because the devices don't talk to each other. And I don't think we're suggesting that the machines necessarily make the decisions, at least yet. But if the machines could exchange data and adjust the flow rate of vasopressors and whatnot, or ingest the ventilator settings in the ICU, that could be helpful. The second then is, and I think the focus of why we're here, is interoperability between the military healthcare system and external organizations, where, as I said, our beneficiaries get a significant amount of their care. And so I'm not necessarily talking about coding and billing information, although that could be shared. I'm talking about clinical data, notes from the emergency room visit in Inova Fairfax, visible to one of our providers or clinical teams at Fort Belvoir or Walter Reed and vice versa. But it's ancillary services too, the lab, the pathology results, the radiology images, being able to see the images if that were possible, and the medications that were prescribed. So it's the bidirectional exchange of clinical information and data that would be important in providing safe and high-quality care. And then finally, the seamless passing of clinical data between what we call our garrison facilities, which is back here in the continental United States or Europe or Korea, and then making that information about that care available to our clinical teams in Baghdad, for example, or Kandahar, and vice versa here. So it's interoperability between MHS Genesis as well as our legacy electronic health records, Alta, CHS, and Accentris, with what we call MC4, the Medical Communications for Combat Casualty Care electronic health record that we have in theater. And the use case there is we provided care in Baghdad. As that soldier is evacuated back then to Balad, to Landstuhl, Germany, and to Walter Reed, is the care that we provided in Baghdad visible to the clinical team on the ground at Walter Reed? And I will say we had concerns about that when I was in Baghdad. And it's also capturing care at the point of injury. You know, are we capturing that care well? Are we capturing the care that's delivered in the air evacuation system? And is all that care visible then to the teams as they take care of those patients? And then the longitudinal medical record with the VA. Soldiers are being discharged from the Army or any of the services. How is the electronic health record set up so that we have seamless transfer of medical information for soldiers with suicidal tendencies in our substance abuse programs, getting care for post-traumatic stress or traumatic brain injuries? Our electronic health record set up optimally to be sure that that medical care is visible to either the VA or our civilian healthcare system. So those are our lenses, and I'll be interested to hear from my colleagues here to my right about what their thoughts are. Thank you.
Thank you. Dr. Ash.
Thank you so much for inviting me, everybody. Again, I'm Ash Zenooz. I'm the Chief Medical Officer at the VA for EHR Modernization. We are an up-and-coming startup inside the VA. Many of you might know that we are in the process of evaluating a contract with Cerner. The Secretary decided and announced back in July that we were evaluating a sole source contract with Cerner. So we're in those negotiations right now. Many of you probably already know or might have read that we have taken a short strategic think through time. I don't want to say that word. We want to take the time to make sure we evaluate this really important topic, which we're all here to discuss today, which is interoperability. Because I think interoperability just means so much to so many people. It means different things. And I think we have an incredible opportunity right now at VA to help move that conversation to where we think it should be going. So just coming back, so my office sits within the larger program office that is in the Office of the Secretary, and I represent the largest stakeholder in VA, which is VHA. We also have VBA, which is the beneficiary arm, as well as national cemeteries and a few other components that have liaisons into my office. So I am the voice of the consumer, be it the patient or the provider, the frontline providers. That is like who my office speaks for. So having said that, like I said earlier, interoperability means so many different things to so many people. We've heard seamless care equated with interoperability. Like, what does it all mean, right? I'm a provider. I'm a radiologist by training. I've done interventional procedures. I've practiced in the academic centers. I go back and forth to the VA as part of my academic practice when I've practiced. And what all of us know in healthcare is that the way we exchange information, even though we've come so far with the electronic health record, with the vendors, is we're still so far behind. I could tell you that I still have a fax machine at my home, and we have one in each of our areas where we practice medicine. So why is that? I mean, the financial sector is so far ahead. I can go to a restaurant and pay with my card and get my 20% off Groupon, and nobody even knows I'm using a Groupon. Things are just like talking to each other, but we can't figure out how to share patient data across these healthcare systems. I think what that means is that this is not just about technology. There's so many more decisions and conversations we need to be having, which I think all of you understand. There are legislative and policy changes that need to occur for us to adequately share information. And that's why we're in this room, and all of you understand this. For the VA, obviously, we have 130 different vistas. They all have data within each of those systems. We don't have standards. Even within the VA, we're trying to sort that out, right? So interoperability, first and foremost, is exchanging data within our own system, within VA, so we can have patients go back and forth and have seamless care. The next circle, I would say, is our closest partner, which is DoD. We should be able to have our veterans coming from DoD going back to get whatever care they need to between VA and DoD to establish a longitudinal record, right? So that's the second layer for interoperability, VA-DoD data exchange that's seamless. The third layer, which impacts, obviously, DoD, we've heard, but now a growing segment of our population get not all of their care, but much of their care out in the community, be it at the academic centers, other parts of the community, solo practice, et cetera. And we have ways to exchange data with them, but we all know it could be so much better. So that's the part we're trying to evaluate as part of this process. And I think the larger conversation, I mean, all of you are here for, is a national interoperability that is like the larger layer. That is, how do we not just exchange veteran data, but how do we exchange data with our other partners on the community? What about the patient-generated data? What about other, what are the other conversations we need to be having? Is EHR the only way to exchange that data? That's the avenue that we need to be heading for national interoperability, because ultimately, I think we need to refocus this conversation, right? The conversation for the last 20 years has been, how do we exchange information back and forth so that the providers have seamless care to provide that information so we can take care of the patient? The conversation really needs to shift to patient-centric. How do we have patient-centric seamless care? And I think that's where we're all going personally, and that's where Dr. Shulkin, our secretary, and the White House and congressional stakeholders, we all want to make sure that this conversation ultimately should be about delivery of care for the patient, patient being able to control their data, patients being able to have visibility into their data, and that's the larger layer that we're working towards out of our program office. So thank you.
Thank you.
All right.
Genevieve?
Yeah, hopefully you can hear me. Maybe. So the Office of the National Coordinator for Health IT, we sit under HHS, and in our name is the word coordinator, and so a big part of what we do is coordinate both across our federal partners, which includes DoD, VA, CMS, ARC, Indian Health Services, probably 10 or 20 other agencies who all have to use health IT themselves, as well as the public sector. And so for the last number of years, we've been heavily focused on EHR adoption, particularly in the private sector, but also within a number of agencies as well. And we've actually done a really good job at that. We're, from the hospital perspective, at about 98% EHR adoption, which is a large number. Ambulatory space is somewhere in the 80-ish%. And long-term care, which has significantly lagged, is actually up above 60%. So that's actually really big accomplishments in a fairly short amount of time when you look at how quickly we've done it, which is honestly thanks to meaningful use, as much as some of us don't like some of the aspects of meaningful use. It did encourage the adoption of EHRs. So what we've been doing since we've done so great with EHR adoption is shifting our focus to two main areas, and that's provider burden reduction in how they use health IT. Sometimes it's called usability, but at the end of the day, it's kind of a little bit more than usability, and interoperability. How do we make sure that these systems actually talk to each other so that when a veteran goes into the public sector, like my dad does for care, his records actually can get shared so that he has seamless care, which did not actually happen when he switched over, but we're working on. Blue Button was very helpful to at least be a nice transition. So as we've focused on interoperability, and that's mostly the work that I lead at ONC, there's a couple of barriers that are out there, and you've heard some of them mentioned already. There are technical barriers, there are policy barriers, there are certainly financial barriers that are just disincentives to sharing, and there's actually a workforce barrier, because at the end of the day, you actually need people who are engineers who can build interfaces and APIs, and we frankly just don't have enough of them. And so for the last number of months, we've been focused on two main barriers, the technical aspects and the policy aspects. On the technical side, a lot of what we've been doing is things that 21st Century Cures asked us to focus on. And so we have really been kind of tightly focused on the charge that we were given there. And so what that asked us to do was a couple things. One, it asked us to lay out something called conditions of certification. So we have a voluntary certification program. We're currently in the 2015 edition. And most EHR vendors, as well as a number of other health IT vendors, come into our program for certification. And then providers use those software programs in order to participate in programs like MIPS and meaningful use and all of that. So part of the conditions of certification include that these vendors now have to come back into us once we've set up the regulation for it and attest that they don't information block. They have to implement something called open APIs that can be used without special effort on the part of the user. So think about how Google and Facebook use APIs. They have to start implementing those same types of APIs. And then they also have to do real-world testing. So right now, a lot of the testing for interoperability happens in a vacuum. It happens just in the test environment. They go through and they get done and rolls out the product to an end user, and that end user maybe actually still can't exchange data or use the product. And so part of the real-world testing is that they actually have to demonstrate that in production, they can exchange data with other users. The open API without special effort, there's a couple things we're working on there. One is regulatory in nature, which will be out in spring of 2018, so I can't comment too much on what's included there. But we've also been working with a group called Smart on Fire, as well as HL7, to develop out population-level FHIR APIs, where instead of sharing just one patient record at a time, you would actually be able to share multiple records in one query or send. And as you think about like VA and DoD and things that they need to do as far as analytics on data, if you have a provider who's in the choice program and they see 100 veterans, it'd be great if VA could actually get data on all 100 veterans at one time so they can run really sophisticated analytics. On the policy side of things, we actually just released our draft trusted exchange framework. So one of the Cures mandates was that we would develop or support a trusted exchange framework and common agreement. Really long title for what's a really short thing at the end of the day. We have a lot of health information networks out in the marketplace right now, well over 100. Some studies actually put it at over 400. Unfortunately, most of those networks actually don't talk to each other. So where we are right now in the health space is where we were years ago with texting. When that first came out, if you were on Verizon and I'm on AT&T, we actually couldn't text each other. That took them coming to agreements to be able to share text messages. Another great illustration is your phone number portability. You used to not be able to take your cell phone number with you when you switched networks. Now you can. That actually took an act of Congress, I believe, to make that happen. But it's the same thing that we want to have happen in healthcare. If you join one network, you should be able to get access to patient data no matter where it lives, even if a provider's on a different network. So the Trust Exchange Framework is intended to deal with the legal and policy variations that networks have in their agreements right now that don't allow them to connect together and exchange data. And some of that's technical, but for the most part, it's actually not technical. It's very much policy. The technical standards for health information networks have been around for years. They're actually pretty solid and fairly standardized. Which data is available is always a little bit different story, but the standard for actually exchanging it is pretty set. And so really what we're trying to deal with are the policy issues that prevent these folks from talking to each other. So on Friday, we released for a 45-day public comment period, which wraps up in February, the draft Trusted Exchange Framework, which intends to sort out some of those issues so that networks who actually agree to the common agreement, which would come towards the end of the year, can effectively communicate with each other. And that includes networks that DoD and VA are a part of right now, like the eHealth Exchange Network. They would be a group that would hopefully sign on to the Trusted Exchange Framework, which would theoretically enable the VA to actually more easily communicate with the choice program providers who might be on a different network than they're on. So that's kind of what we're working on. We've been actually quite busy and had a lot going on, but look forward to questions.
Thank you, all three of you. Great opening comments. As you can see, we've got the experts here today, so encourage us all to be part of this dialogue. But I'll start the questions with, we've heard a little bit of this, but we're increasingly aware of the technical and policy definitions of interoperability as through 21st Century Cures, and HIMSS has a definition, Office of the National Coordinator has a definition, at IEEE, et cetera. So interoperability between DoD and VA and what my term downtown care providers. From a practical perspective, Dr. Cordts, maybe starting with you, what does interoperability mean for you as a provider or you as a patient or caregiver?
Okay, I'll give my thoughts on that. I'll just give a little recent visit that we had. We're negotiating agreements with health information exchanges one by one, and we met with one recently, and the question that we had was, okay, your hospitals provide a lot of care to DoD beneficiaries. Are you able to see the care that we're providing at Fort Belvoir or Walter Reed, for example? And if you're able to see the care, is it in the workflow so that the clinical team can see it when they're seeing the patient? And is the information that's provided the information that you want to see? Do you want to see a discharge summary from an inpatient admission at Walter Reed, for example? And so to me, it's the exchange of data in both directions. Are they able to see the care we're providing? I call it inside the gate. And then are they able to see the care, so are they able to see the care we provide inside the gate, and are we able to see the care they provide outside the gate? Is it part of the clinical workflow, and what is the quality of the data? Is it sort of minimally acceptable data, or is it providing you the richness and the kinds of data that you need to be able to make clinical decisions when you're seeing our patients and vice versa? That's my thought on that.
Yeah, I completely agree with that. I think it's basically, are you getting the data you need to take care of the patient at that point in time, right? So is it coming over as a fax? Are you just getting something on paper and you have to read through all components of it? Or is the data actually in a format that can populate back into your EHR in a meaningful way so that if you're pulling up if somebody's a diabetic and they come in and they have glucose levels that were out of range elsewhere, do you have to go sifting through all of those documents to say, where was that glucose, or does it automatically populate, like you said, into your workflow and you can see, wow, look, there's new data that's coming in from the outside that shows changes in this blood glucose level. Perhaps I should start looking at this patient to better manage their sugar levels, right? So It's actually data that's coming in a way that's useful and data going out to the outside parties so that they can actually take care of the patient and have a comprehensive plan. I think also, we talk a lot about like discharge notes and data. I think we need to start thinking about like imaging data, right? So do you have access outside of just reports? Because a lot of our patients in the VA are going out or coming in for complex care, like cancer patients. You don't want nobody, I'm a radiologist, so this is like very near and dear to me, but I know for a fact that when I get somebody from somewhere else, another VA, another facility that comes in for follow-up care of a cancer patient, you must absolutely look at the other images to compare. And if you don't have access, and it doesn't need to be in a format that I download and put it and do analytics on it, but at least at a very minimum, I should be able to look at the images and say, was this mass there? Could I see it? Has it changed in size, shape, et cetera? Are there more? I think just reading a report from somebody else isn't good quality care. So I think that's sort of what interoperability means, getting the whole picture.
And I'll give one follow-up to Ash. If we have a diabetic patient enrolled, I just used the use case at Fort Belvoir, and they get a hemoglobin A1C in the TRICARE network, I don't want to have to go search for that. I want that to be automatically ingested into a queryable data field in our electronic health record and then be countable and capturable in our HEDIS measures without having to have someone go search for it and enter it manually into our electronic health record. That's one. We've also had kind of an interesting conversation, follow-up to Ash, with the dental community and the sharing of, I don't know if the VA's done any work on this or Genevieve, but the sharing of dental films. The use case for us is we have reserve component soldiers come in who have received a lot of dental care in the civilian community. We'd like to be able to see their films. Otherwise, you're faced with, of course, duplicate ordering of films, duplicate lab tests, et cetera, et cetera. So that's just a follow-up.
So I think part of what you're hearing, hopefully, is that interoperability isn't solve it and you're done, right? Interoperability is a moving target. As we exchange more and more data, what we think of as interoperability starts to shift. So, 4 years ago, before we had direct messaging, it was, can I just get the data from point A to point B, right? And by and large, you actually have a number of abilities to do that now, mainly via direct messaging. As we've started to see that shift, now we're starting to get into the conversation of it does need to be integrated into the workflow, right? So I'll take the opioid issues, right? Almost every state has a PDMP, except for one, perhaps. But the issue is that for the most part, that PDMP is not integrated into a provider's workflow. So if I'm ordering a medication, I actually have to leave out of my EHR system, log in, most likely using multi-factor authentication into a PDMP that may be running very slowly depending on the technology stack that's being used and the broadband that I have in my office. Find that patient's information, see if they've been prescribed, and then go all the way back into my EHR system, potentially actually have to log back in because I might have timed out, and continue to order that medication, right? Versus I'm in the process of ordering a medication and the PDMP data actually shows up in my ordering screen and I can see if that patient has had multiple prescriptions and whether or not I should order that medication. That type of workflow integration actually is becoming more and more important because physicians, as we all know, have about 15 minutes with most of their patients unless they happen to be in a value-based payment model. Maybe they get more, likely they don't. So I think those types of things as well as data quality issues, again, it is a sign that we have more exchange of data, that the bigger complaint we are starting to hear is workflow integration and the data quality sucks. I think it's actually, it doesn't sound good, but it is a good thing because it means data is actually moving, which is a really good thing. And so I think as we think about interoperability, particularly over the next few years, I think it's starting to figure out how do we do better workflow integration? How do we convince vendors to allow innovative companies to build hooks into their EHR system? And by hook, I mean this app might be from a third-party developer, and we just want to be able to integrate it into our workflow so we can use it really easily. There's a lot of companies who want to do that. That's a very difficult negotiation right now. And then how do we deal with the data quality issues? At the end of the day, and Dr. Rucker, the national coordinator, talks about this all the time, physicians really aren't incentivized to update your problem list. And I have an excellent physician who is on top of her EHR. We have an excellent relationship. I'm very involved in my care. There's at least 10 problems on my problem list that I do not have. I may have had them very briefly. I do not have them now. And it's because from a financial perspective, there's no incentive in a fee-for-service system to really take the time to do that because that's not an easy process. And so we have poor data residing in EHRs, and then that data gets exchanged, and it just compounds the problem. Couple that with semantic and syntactic issues of, like, I might say kilograms and I say kg, but you spell out the word and our systems don't know what that means. That's becoming a significant issue that we have to focus on. But all of that means that we're making progress. And so I think that it's really important to note that getting into the workflow and data conversations means that we're doing a better job on the connectivity piece.
So I want to feed off of the data quality comments for a moment. You know, take us from several years ago, the issue was, I don't trust the other provider, so I'm going to redo it myself. Is it less that and more, hey, it's just the quality of data is not so good, I may, you know, are we turning a corner within the community of, it's more of a, hey, I want more robust data than I want to do it myself, and therefore increase costs?
So I'm not a physician, but I will say I think it's still a little bit of both, plus you couple that with the fee-for-service system that does not motivate me to not redo that test. At the end of the day, that's just still the world that about 60 to 70% of our care resides in, right? But I do think it is starting to shift to the data quality piece of things, and some of that is just being able to dig through what might be hundreds of pages of a CCDA document. But to your point on sort of like the exchange piece, and it's always good to like look at where we came from. You know, 5 years ago, I was exchanging a CCD and you were exchanging a C32, and we actually couldn't communicate at all because we had totally different data formats. And now we have the CCDA, which is far from perfect. I say it because everyone will roll their eyes at that. But we have the CCDA, which is you know, a step in the right direction. And then with FHIR APIs, where I can actually just ask for specific pieces of data, I think we're just continually taking steps in the right direction and have to be somewhat patient as we get towards that all data stuff.
I agree with Genevieve there. I've heard less about trust than I have about data quality. And it's things like, exactly as she said, that problemless reconciliation. Of course, that's right in our face because we're pulling data from our legacy electronic health records into MHS Genesis. We're asking our providers to reconcile those problem lists. And you can see some quite long problem lists from, as she said, some problems that have been long since resolved, but, you know, or perhaps still on the problem list. Same thing with medications, same thing in a number of areas. So I've heard more about data quality, perhaps, than I have about trust. So,
You know, I'll just add and say, I think this is why it's really important, particularly at the federal level, for different agencies to come together to have this conversation. We need to, I think Genevieve said this, we need to start moving away from fee-based service, and I think this will really help whether it's an issue of just data quality or redundant studies or redundant imaging, or whatever it is that we're doing, right, for adding to the cost of care. If you start moving towards outcomes-based care, value-based care, where you're evaluating payment models, you're evaluating claims data. So if I refer out, for example, in the VA, if I'm sending care out to 5 systems for cardiothoracic surgery, and I have claims data coming back, and I can actually look at it, and the data it's good data, not just the data to provide care, but the data coming back on the claims data. If I could look at it and say, look, at this hospital, they billed us for 8 different CTs after they got there, and the patient still didn't do so well, and they still had to come back in for pneumonia and readmission, and their care in that hospital system was 20 days longer than this other hospital where they took care of the same patient with the same level of complexity for cardiothoracic surgery, but they recovered really well, and they had the same factors, morbidity, mortality factors when you look at it when they went in for care. So I think that we're moving into an era where the analytics will become really, really important. And it's not just analytics on the current system of the patients who are in the system, but also at the system overall. Like you said, moving towards value-based care. And the only way you do that is if you have good quality data that can actually be analyzed.
So with all the focus on data sharing, interoperability, and the quality of the data, how do we keep the veteran, active duty, family member, retiree, caregiver, et cetera, at the center, so that we don't leave them behind as we're solving this?
I'll give a shot here and then turn it over. I agree with one of Ash's comments. We've had these discussions about who owns the data. Who owns the medical data? Is it the providers and the clinical teams or the patient? I guess my view has been the patient. And I don't know if that's shared widely or not, but lots of discussions about that. And, making the data available to the patient for them to look at. And then there are discussions about, okay, can they look at it, knowledgeability, et cetera, et cetera. Maybe the day will come and we have AI on top of that can do some analytics on this data if there's 1,000 pages of data. But then having the data available to the patient to share with whomever they want. And so to me, that's kind of a fundamental concept. The patients own their data. And, I think we as providers tend to take this very paternalistic approach to that. It's our data, by golly, we'll make the decisions about your care. And so that's kind of the way I've been thinking about it. I don't know if that's widely shared necessarily, but we've been having those conversations right now on how can we make it easy for the patients to access their data and then share it with whomever they'd like to.
I mean, you heard what I said when I first started. I think we have to change that discussion. Again, I don't know if everybody thinks this. I know that there are certain organizations and systems that will disagree, but ultimately we're doing this not just for the patient, but like consumers, right? It's not for people who are just in the hospital who are patients, but it's for people that are well, that are walking around. Like, we all want access to our data. We want to be able to use our Apple Watch and make sure that we're, sleeping better or whatever the trends are. So I think this is about, I don't know if consumer is the right word, but it's about people, the humans that are walking around, not just ill patients. So I think if we have that perspective, the place where we're going will be, I think we're going to go down the right track. So I think with that in mind, the patient portal, I don't know, I go to several different places for care. I'm all over the place. I move constantly. And I think I have 6 different patient portals on my phone. And none of them can exchange stuff with each other. Even though I know that there are different vendors announcing that you can send stuff, it just really isn't there. And if you look, the amount of information that's on that patient portal isn't really useful. It's like some basic information. It's not really adequate for me to go from center to center and send care, right? So this is the kind of conversation we need to be having with our federal partners, with ONC particularly, with CMS, and say, hey, we need to incentivize these providers and companies to share the data with the patient, so that when I go from facility A to facility B, if it's not inside the VA, then I should be able to just push a button and say, I request this information, or I want to share this information. And I think in the VA, we have different restrictions for patient opting in and opting out than others on the outside. But at the end of the day, it's the patient that makes the decision whether they want to share that data or not.
And I'll make a follow-up there. As we've deployed our new electronic health record, we have a patient portal. One of the newer aspects, we've been sharing data through our technology and our legacy systems, but now the notes are available to the patient. And so that's caused lots of discussions, especially in behavioral health and some other specialty areas. But it's changing the nature of the conversation between the providers and the patients. The patients will go in and read those notes, some of them, and they will perhaps challenge some of the information that are in their notes. And so I think that makes for a richer discussion. The patients are better able to understand information about their health and their health care. And so we think that sort of patient portal and transparency has been beneficial.
Sitting here trying to figure out where to start with this question because there's so many things. I think when we talk about ownership of data, everyone wants to own the data right now. At the end of the day, there's obviously a financial price to patient medical data in a lot of different ways. Part of what we're very focused on at ONC is trying to shift the market away from competing on hoarding data, which is frankly what they do right now, At the end of the day, most large health systems, payers, throw everyone in the mix, want to keep that data to themselves because they're doing a lot of things with that data, which is fine. But it's not fine when patients can't get their own data because you're trying to hoard it for competitive advantage. It is not okay to ensure lock-in to your health system because you're not making it easy for patients to get their records so that they can go wherever they want for care. And at the end of the day, that's what happens right now. So I've told this story a couple times, but not to this audience. Right after or before I took on this new role at ONC, my niece, who has had some medical issues, had an emergency situation occur. And rather than taking my niece to the closest emergency room where my sister was at the time, she had to take her to the emergency room that was further away because they had her medical records. And she knows, because of what I do, that she's not going to have access to her medical records if she doesn't go to the hospital where they were created. And so she ended up getting good care, appendicitis, had to have surgery, but my sister was locked into the health system that she had gone to for some original testing because at the time she didn't know what was going on. That is just simply not an acceptable situation in this day and age. Consumers and patients deserve to be able to make choices about where they go for care, both from a quality perspective and a cost perspective, and they can't do that if they don't have their records. So at ONC, there's two ways that we're focused on this. One is open APIs, so being able to have an app that actually has an API that goes into the different EHR systems, and you can pull it onto your smartphone and get access to your data and pull it together. That's sort of one avenue, and that's a work in progress. Some of that's tied to meaningful use and MIPS requirements on the provider side. Some of it's tied to standards. The second is with the Trusted Exchange Framework. So when we built out the draft Trusted Exchange Framework, one of the permitted purposes that we included is individual access. Right now, a number of health information networks, or I should say most, don't actually allow individuals to go into the network and use that to access their data. There's a lot of reasons for that are completely valid reasons, but at the same time, if an individual could use the network just like a provider does to go in and pull their data, be able to do a query across all these different networks and pull together in one place all of their health information, that's really, really powerful for them to be able to do it simply and easily one time, continually pull it together so that then they can choose where they go for care and they can seek out the best care possible.
Now it's your turn. Questions from the audience? Yes, sir. Oh, and then Nate.
Sharing of information, I know from working closely with the VA-DoD where we would go out and get it, and then have a requirement of the beneficiary opting in, where you guys opt out.
So there are specific things going on that I can't really discuss right now, but in general, VA patients have to opt in to share their data. There was some legislation that was put in, I believe last year, that passed through that, when we are exchanging data with our community partners, we can, they're essentially considered opt-out for those purposes. Of course, with the exception of 42 CFR, which is different components of mental health, et cetera. So we have to be able to segregate data. I think when we're talking about interoperability, it's really important to have the patients, generally, I think if you ask someone, do they want to have their data exchanged so that the quality of care is better, they're going to say yes. In fact, I think in the previous administration, they sent out a couple of million questionnaires that went out, and I think they got somewhere on the order of 250 responses back, right? Patients just are not engaged on this issue, and they don't, when you're saying, are you opt-in or are you opt-out? What does that even mean? Right? So I think the conversation has become stale, and we need to restart the conversation with our partners on the Hill and with ONC and others, because there may be small focus groups that really understand this well, and I don't know exactly what they're using this opt-in and opt-out conversation for, or what purposes, and I don't want to say there's anything nefarious, but I think the general population, whether it's a veteran or a general patient, everybody wants our data to be available to us, and we should be able to share our data, and we want our data to be shared when you go from one place to the other so that you're getting good care, right? In general. There are people that'll say, I don't want my data shared, and that's okay. It's the patient's data. They have to have that choice. But I think having the general community engaged so that they understand what patient opt-in, patient opt-out means is really important. Just sending out flyers in the mail to people and asking them, I don't think is the right way to engage. And I think this discussion is deeper and broader. And some of those things are actually coming into play right now.
So just by show of hands, do folks understand when we say opt-in, opt-out, what that means? I see heads nodding, so I'll take that as a good sign. I think in addition to the VA requirements on opt-in, there's a huge variation across states in state law around opt-in versus opt-out. Majority of states are opt-out. There's a number that are opt-in. There's some that actually require written consent versus verbal. And it's really just a hodgepodge that, frankly, makes interstate sharing of data quite difficult. And that's not even dealing with the 42 CFR Part 2 stuff, which is even harder, particularly as you think about opioid crisis and things like that. So, historically, so when we talk about policy issues that prevent exchange, that opt-in, opt-out issue always comes to the top of the conversation. Now, I would say I think some of it is a little red herring-ish because people don't want to share data and sometimes blame things like HIPAA for not sharing. But at the same time, I think from a policy perspective, I'm not really holding my breath that we're going to get that worked out, frankly, because state laws are state laws. And as ONC, we don't have authority to trump state laws, obviously. But one of the things we are focused on is electronically being able to share that consent. So for the patients who really do want control over their data, being able to easily electronically share it when you exchange data is really important. And we've not done a great job to date on standards for that. We've had a number of fits and starts, and people will focus on it, and then it kind of falls to the background. And I think as we do something like the Trust Exchange Framework, it just becomes more important that those standards get worked out. And so, there's a couple of groups, Care and Health Alliance, who's very focused on individuals and getting consent, and then Care Quality, who's also working on a way to share consent that we're really hopeful will start to make some progress. So even if we can't deal with the opt-in, opt-out issue, which would be great if we could, but if we can't, we can at least easily electronically share that consent. So when a patient does make a decision to either opt in or opt out, you can get it easily and not have that as a prevention of sharing data. So.
Other questions? Sue, I think you had one.
Well, Congress made information blocking illegal in 21st Century Cures, which I think is the first step. We certainly at ONC are working on the regulation that surrounds that of what is and isn't information blocking. I think that's honestly your first step, is just saying that this is not an acceptable practice, right? Which Congress has said, and we are highly appreciative that they said it, frankly. I think around like the trust exchange framework stuff, there is a clause in 21st Century Cures that says federal agencies are encouraged to use their contracting abilities to encourage participation in something like the trust exchange framework and common agreement. So that clause is certainly in there, and we've been talking very working closely with our federal partners to understand how they might be able to use something like the trust exchange framework. But I'll leave it to you guys on how else you might encourage.
Yeah, absolutely. I think as we are reevaluating our community care contracts, this has to be part of the discussion where, we had data sharing, data coming in linked to payment, and that was delinked. But, we don't have to link it to payments. Maybe there's something else that we can do, but we need to start having that conversation where it says, for you to participate in our integrated network, you have to be able to share data electronically. Now, that will leave out a lot of folks in the rural areas who don't use the electronic medical record. A lot of the veteran population will be impacted by this, so we have to keep that in mind when we make those decisions, build our budget, talk about, these folks out in the rural communities, they're core to providing a lot of care to our veterans. We don't want to drive veterans to have to drive, 40, 50, 60 miles or wait for care. But at the same time, there are ways we can address it. Perhaps we can provide a way for them to electronically exchange data. Maybe we can give them licenses. I mean, there are a lot of things that we can think through on how to engage the community partners that are in these areas, but we must have data exchange, and it's better for it to be electronic than not. And I think we're going down the right path. I think we also need to start having the conversation about telehealth, right? A lot of these providers are using telehealth, and I don't know, if there's, and I know, there's no standardization of the telehealth records coming back in, and we need to start having those conversations because a lot of these folks in the rural areas, we need that information to provide comprehensive care. So.
I think that's good. I share those thoughts. We have large TRICARE contracts. And as I said, more than 50% of our care is provided by the managed care support contractors in the TRICARE network in civilian hospitals and healthcare systems. But you could imagine conversations, where we're looking at our value-based care models, and what is it that we can do to incentivize the exchange of medical information between our two healthcare systems. So, and what other sorts of value-based care models would help incentivize contractors to do that and facilitate that exchange of medical information. So I agree with the comments here.
Yes, ma'am.
Yes, so far no one is a part of it because it's draft for comment. The timetable that we're working on is towards the middle to end of summer. We want to have a recognized coordinating entity who would be an industry organization who can, there's a lot of details around this, but they can act as a governance entity for us, select it, and by end of year is when we're targeting to have the final Trusted Exchange Framework and Common Agreement published in the Federal Register as well as on our website. And then from that publishing date, the qualified health information networks would get a year to sign on and come on board. We certainly have worked very closely with VA and DoD as well as a number of other federal partners to ensure that what we're building into the framework works for them. And so we've had a lot of conversations around things like permitted purposes and how do we deal with the consent issues and all of that. And we will continue to have those conversations to make sure that when we get to the final common agreement, they can use the networks that they use now to be able to connect and use the framework to exchange. I will say that Cerner is part of the Commonwealth Network, which is a national network. They may also be on eHealth Exchange, I think. I see nods, so that seems right. So we would anticipate that both Commonwealth and eHealth Exchange will hopefully sign on. It is voluntary, but we believe that the market is going to push that direction. And so certainly if they sign on under one of those networks, Cerner would be able to exchange data just as would every other EHR vendor who signs on to one of those networks. I don't know if you want to add it.
So just to add on to that just a little bit, HIMSS as an organization, as a nonprofit, we've worked over the last year on a interoperability call to action, and as part of that, we did an environmental scan. So we looked at some of the major efforts underway, carry quality, through the Sequoia project, Commonwealth, integrating the healthcare enterprise through initiative, all of those. So we'll make sure that those that are here, as a follow-up, we'll make sure that that information is available, so you're able to understand who these organizations are as they build on the fabric of interoperability. And I will say that, my experience in the community is that each of the agencies have been very much part of each of these efforts, dating back to the CHI. I can't remember what it stands for anymore, but it graduated to the Federal Health Architecture, and so there's some great resources that we have. But so along those lines, before we go back to the group again, so are we really starting from scratch, or is there baseline information that's already sharing? Is there like millions of data points that are flying around already, or?
So I'll start. I don't think we're starting from scratch. We're sharing information right now with a system called Joint Legacy Viewer, which allows our providers to see medical information provided in the civilian sector, so our TRICARE network, as well as in the VA, so that's good. We also have the interesting current challenge of we have 4 hospitals in the Pacific Northwest on our new electronic health record. So, and we're currently on a 5-year deployment timeline. So the majority of our healthcare system is using the legacy electronic health record. How does, again, I use the use case of Fort Belvoir, if a patient moves, a family, a service member moves from a hospital in the Pacific Northwest to the National Capital Region, how do they see the care provided in MHS Genesis? They see it in Joint Legacy Viewer. So I would say we're not starting from scratch. Now, are we where we need to be? No. And we're doing that, and we're making sure our providers and our clinical teams know how to access that data. The training is important. It can be available, but do they know that it's available, or are they still receiving medical information via fax in their office? So we're in the process of making sure the providers across our healthcare system are aware of how to use Joint Legacy Viewer to be able to access these kinds of data.
I would say definitely not starting from scratch. As we build out the Trust Exchange framework, we worked really hard to build off of what the industry has already done, but to Paul's point, expand it much further and hopefully faster. I will say that I think as a nation, we've done a really good job of connecting hospitals and large health systems. I think they're not really the ones who feel the interoperability pain. They feel the workflow integration pain, but they don't feel that I can't get the data pain. Ambulatory, behavioral health, and long-term care is a totally different story. Those folks, because they're not last mile connectivity from the sense that most care takes place there, but from how many different EHR vendors you have to deal with, the lack of IT resources that physicians tend to have who are independent practice, they're almost like last mile connectivity for us, even though they actually should be first mile because they have the majority of your data. We're not starting from scratch there, but we are starting from a pretty low connectivity place. And so as we build out the Trusted Exchange framework, we tried really hard to focus on how do we get those folks connected, where historically we've really struggled. I've worked with regional HIEs for years. They've done a really good job, but on the ambulatory side, that connectivity has been very, very difficult for a lot of different reasons. And so we're hopeful that we can start to build up that connectivity, because I think it's something like, like 80% of care happens in the ambulatory space, not in the hospital. And so I think that's where we need to really focus a lot of our time and attention moving forward.
Yeah, I agree 100%. I think, like you said, the way we practice and the way we care for our patients has changed, where it used to be hospital focused, and now it's almost, like you said, 80% in ambulatory care. And I agree. I mean, we're not starting from scratch, but we're not starting from a good place either. So as I do my listening sessions, one of the things I see is a lot of independent practitioners that contract or part of a practice group, even in a hospital. So they go in and they see patients in a hospital. The hospital uses a particular vendor. They have access to the HIEs, but they don't use them because as in their independent practice, they don't use electronic health records, and they don't understand how to tap into the HIEs, or, well, what does DERSA mean? Like, a lot of this is like education and incentivizing folks to understand this and incentivizing them to use it, because otherwise it's just extra time in their day when they're not seeing patients or not spending time with their families. So I think that's what we need to be concentrating on, these independent providers, the rural practice providers, the non-MDs that are now coming into practice and growing, like our nurse practitioner community. It's a growing population who, the VA obviously has been in discussions of like utilizing it in the private sector, so I think we need to have those conversations to talk about interoperability here.
More questions from the audience? Yes, sir.
I think I should get $1 million if I ever go to a session and don't get asked about patient matching. I'm just saying, if anyone wants to put that on the table. So patient matching is obviously an issue. I personally have spent a lot of time on this. I was lead on the report for ONC from 2013 now. Oh my gosh, it's been a while. Around patient matching. And actually, shockingly, we have not made significant progress in the patient matching sector since I did that report in 2013. I say slowly because that makes me a little sad inside. So it is a big problem. I will say, I don't know that unique identifiers solve the problem, right? Because you still, at the end of the day, have to type something in for that, and someone can still type it wrong. And so there's a couple of things that we need to think about. One, some of this is a data quality issue. The folks at the front end who are inputting your information are typically registrars or front desk folks. The turnover ratio in those positions is like 75%. So you have folks come in who aren't trained, who don't understand why it's important to record your patient information correctly, because they don't really understand the downstream impacts. To address that piece, ONC has done a couple things. We actually released a training module that is specifically for front desk registrars to help them understand not only the patient safety implications, but give them some best practices around how they can better enter patient data. And then we also recently released something called the Patient Demographic Data Quality Framework, because we just like to use the word framework 20 million times for different things. The PDDQ, as it's called, actually allows practices. There's one for the ambulatory sector that's a little bit easier to get through. There's one for health information exchanges and health systems. It lets them analyze their data handling practices and figure out where they could do a better job on patient demographic data, try and deal with that data quality piece. I think on the patient matching front, there's a lot of new technologies coming into play. I'm not going to name vendor names. While I could do that, there's, I think, a lot of vendors who are trying to think about this in a little bit different way than we have historically, and bring to bear other data sources that we've not historically used in the health system for matching data. So things like taking all the data that some of the other companies might know about you and matching it in with your patient data to figure out that you are who you say you are. I think certainly there's folks who are working on voluntary unique identifiers, which we're always supportive of folks coming up with voluntary unique identifiers. But again, I think near term and even longer term, we're probably using patient demographic data for matching, right? Because at the end of the day, biometrics are really great for in-person identity proofing if you can get a patient to agree to that, which I personally would not want to do that. I'll give it to Disney World, but not the health system. Because Disney World won't let me in if I don't give them my fingerprint, right? They still have to treat me at a health system if I won't give them my biometrics. But there's a lack of standardization in biometric data. So when you're trying to match data and the patient's not in front of you, there isn't an easy way to exchange that biometric data attached to the health information so that you know that it is the right patient. So I think there's a lot of technologies that will come into play, but we're still on kind of a long-term path on that. So.
And thanks for the question there, Jordan. We also have a huge victory in the first session of the 115th Congress around eliminating or decreasing the prohibition on these ONC and other parts of HHS actually getting involved in the national patient data matching and having a national strategy. There was an appropriations prohibition that's now been we've overcome that hurdle. So now ONC and CMS and others can really engage in the dialogue.
I totally forget. We did actually do the algorithm challenge at ONC. I forget about our own initiatives. That actually we awarded the winners to, I think, just a couple weeks ago, probably 2 months at this point. So we are continuing to work on figuring out how we make the algorithms work better, because that is probably just how we're matching for the near term at least.
Yeah, and the other part of what ONC has done is with HIMSS, we have the innovator in residence who's been looking at what is the attributes, the best attributes of an algorithm, and that paper was published with folks from Regenstrief and Northwestern University and about 18 other academic type organizations, and then once they've got the attributes, they had the challenge. So a paper's coming out in the spring about that as well. All right, next round of questions. Yes, ma'am.
Yeah, I mean, I think EHRs are essentially, I mean, when we talk about EHRs, we're talking about transactional system. So I think the industry has been moving this way, and for VA, I think we want to push that discussion where we start moving it into, like I said, an analytics space where you can actually use that data to analyze the data that's going on, so you end up with like better care, right? And for that, you're going to need research. So we want to engage our research partners within VA and external to VA. We encourage them to come in and work with us as this program goes to understand, like if we select, for example, a specific clinical practice guideline, we want to see if that goes into the EHR and if it's being utilized, if it actually works in reducing, for example, suicide. So there's a lot, or for opioids, if we put in a workflow that says, someone comes in and here are the ways to take care of it, here are the options, and you want you want our folks on the inside, the researchers, to look at it and publish that information. I think there's a lot of disinterest on part of certain vendor community not to publish data on EHRs, but we in the VA want to encourage the research, and we want to encourage this, and whether we do it as part of the contracting process or discussions with the Hill, we're going to say we want to start publishing data which involves research on is this useful? Is checking this thing that's recommended, blood pressure every time somebody goes into the hospital, is that useful to the care of the patient? Or is that just extra burden? Putting on like some clinical reminder, is that useful? I mean, we have overall 21 million patients and about 7 to 9 million active patients at any time. And we're going to have a lot of information that's going back and forth. And so we can contribute to the general research community if we involve all of those folks in looking at this information. So I think there's tremendous opportunity here. I personally believe that this conversation with VA-DoD, with VA as a whole, just looking at the contracting process for this, will change how EHRs are done. It's going to be, I think we can push a lot of the buttons as part of our contracting process to push the vendors along, not just with the vendor that we're going to contract with, but with the other vendors that will be exchanging information with us. The other part of the EHR that we don't talk about is the revenue model component, where we're a payer provider in the VA, and so health plans, we need to start linking our referrals and authorizations and claims models back to the EHR so we can analyze. And in the VA, we need it to link to the beneficiary arm. So again, that's another part of interoperability. So we need to be able to link all of those and see like what works, what workflow works, what's targeting these physicians, what's leading to fatigue. There's a lot of research that can come out of it, so, and I think we're looking forward to participating.
So I'll give some thoughts here. We've been thinking about this question, and we're thinking about enterprise data management as kind of this foundational piece right here, and we've done an assessment of the maturity of the way we manage data at the enterprise level, and there's a scale of 1 to 5 there, from being very, I guess, immature with disparate kinds of nomenclature, et cetera, to being very mature. And so we've done that assessment and are asking ourselves, how can we accelerate the maturation of the way we manage data as an enterprise? And huge opportunity here to do this in conjunction with the VA, but thinking in 3 domains. One is to better support clinical care, but without ignoring process improvement. How can we learn from our own data? You know, I sort of have in my mind Archimedes at Kaiser, where when the primary care provider walks into the clinic in the morning, he or she has 3 recommendations from the artificial intelligence they put on all that medical data the night before, saying add 10 milligrams of Lipitor for Mrs. Jones. Make an attempt to reduce her blood pressure by 20 millimeters of mercury, something like that. So better supporting clinical care, better supporting process improvement, and better supporting the researchers that need access to that data with standardized nomenclature and data fields that can make their research better and more valuable, and we can learn more. So I guess that's kind of the way we've been thinking about it, or I've been thinking about it.
Yes. We have not. So we have to remember that in the VA, we have a fairly mature electronic medical record. We have a patient portal that's active. We've been sharing notes, records, et cetera, with our patients for a long time now. We were at the forefront when this came about. It's a system that actually works really well in terms of a transactional system. It's just there's so much, the vendor community has gone so much farther along with that research that we don't, I mean, we're not in the business of developing things, so we just haven't caught up. So having said that, yes, we are very much engaged with analyzing the genomic data. We have partnerships with the Department of Energy where we're using their computational ability to look at our data. We have relationships with the, not specific to genomic medicine, but with the DHS in looking at biosurveillance and what we can do in that space. And we're having continued conversations with DITRA, other components of DoD. So yeah, I mean, I think it's not linked right now because we don't have that ability, but as these conversations move forward, it's really, really important that we start thinking about those arms as part of the, I see it as like a digital health transformation, not when I say electronic medical record, we sort of just think about typing something in, it goes in, it stays, and it's available for somebody else. This is a digital revolution and a business transformation for us, and all of the different arms and components that feed data in, and what we do with that arm, it's not just with that particular vendor or that particular EHR. We're going to have lots of different connecting arms, whether it's through the APIs or whatever model we end up going with, essentially leading to a platform where you're able to bring in lots of different data, right, and analyze it and spit out something that's useful and meaningful.
I'll give a short answer there. We do look at genomic data now. It's certainly being looked at for research. I think some of it's being used in clinical care, but this is of great interest to us, and it sounds like the VA as well, of course. And the use case I give is the Cerner CEO spoke at a conference last year and talked about I'll have this slightly not accurate, but a 22-year-old woman who came into the emergency room with sudden cardiac death. And she was resuscitated successfully, and then her genetic profile was conducted. Turns out she had a gene that predisposed her to sudden arrhythmias. And then turns out, so she was fitted with an implantable defibrillator, along with 12 to 14 members of her family who had the same gene. So we're definitely interested in that concept and how we can better leverage these genomic data as an enterprise. And so I think we've got some maturing and a ways to go there. Some of it's being done, but I think we can do more.
Just say, from an ONC perspective, we have a partnership with NIH. There's two, there's Sync for Science and Sync for Genes, and it's looking at using some of the new FHIR specs to actually be able to move around genomic data. Some of it's connected to the NIH All of Us research program. So I think their goal was to get like 10,000 folks signed up, and I think they're either very close to that or have actually hit their first goal. But those are, I think, really impressive initiatives, and we're very excited. But we also still just need to get basic data shared. And so I always want to temper and be a little pragmatic that it's great to think about interoperability of genomic data, and we need to get there as a country, but I also just need my accurate medication list shared between my providers. So.
Yes, sir.
So I would say OCR would be the place to direct that question, the Office for Civil Rights. They maintain all of the HIPAA rules, and then there's a lot of state laws around that. I do think there's at least one state that actually specifically says in statute that patients own their data. I believe it's New Hampshire. My special assistant is nodding, so I think that's correct. But other than that, I think having a conversation with OCR about that would probably be the best option.
So as we near the end of our 90 minutes, what's the greatest opportunity or challenge your office faces for 2018 in interoperability or anything else?
I'll start. Biggest challenge is how will we leverage our new electronic health record to transform the way we deliver health care in the military healthcare system, along with our TRICARE partners in the VA. How will we make the care safer, higher quality, more efficient, more cost-effective than it is right now? I think that's kind of the biggest sort of high-level challenge for our system. In our healthcare system also, we have Army, Navy, Air Force. And so the standardization of our practices, of our clinical and business processes is important to us, especially when you're deploying an electronic health record. Do we have 3 different ways of delivering primary care in our primary care clinics, or can we agree on an 85% solution of one way, allowing for some reasonable local variation in the way they deliver that kind of care? Huge opportunity with the VA. Could the DoD and VA agree on a common set of a small menu of pain scales that we could agree on, and both of our healthcare systems could use them? Could we agree on a generally common way of treating a patient with low back pain and then measure it? And could we follow the natural history of a patient with post-traumatic stress to see if our therapies while the patient is being cared for in the military healthcare system are enduring and effective? And when the patient's being cared for in the VA, are they able to function and do their job and go to school or whatever it is that they want to do? So I think we have a huge opportunity now here with the VA, and so we're looking forward to that, and those are the conversations that Ash and I have been having at this point. The interoperability, I think we've talked a lot about, and as I've said, is very important to us. I think we share the importance as 2 healthcare systems here in wanting to get an understanding around the quality of data and the effectiveness of the data we're sharing.
Yeah, I mean, I agree 100%. I would say, and I've said this before, I think our primary responsibility is in leveraging this for business transformation and changing our operational model. But for me personally, I feel like we have to strike the right balance between patient-centric development of things versus not shirking our responsibility as a care provider. Particularly for the VA, we have a responsibility to manage the care of our veterans, offer guidance, to have care coordination, and saying patients own their data, we don't have access to their data, so we don't have to worry about that is not the right thing to do. So patients must own their data, I agree, but we also should have access to that data, bring in all of that information, share the information, and we have to have educated, it's not an educated guess for the patient. We should be able to provide guidance on where they should go, where they should seek care based on data that we're analyzing. So I feel like, for me, every decision we make, we have to think of the patient at the center and ensure that we're not shirking our responsibility as the care management and care coordinator.
I think biggest challenge is really just shifting the market, frankly. whenever there's a ton of money in play, folks are going to be very resistant to change and are going to want to stick with the status quo where they're making a lot of money. And so I think shifting the market and convincing health systems and payers and vendors that the data itself is not where you should be trying to build your competitive advantage or make your money, and that the data services is really where you should be focusing your time and energy, like every other industry has done, is a huge challenge. We talk about it like it's not, but it is a really big challenge. And so I think that's one thing we're dealing with. I think opportunity-wise, 2017 was a bit of a quiet year for ONC. I think that was actually a number of the analyses at the end of the year is like, hey, they didn't do much. That's actually because we were doing a ton of work behind the scenes. I think 2018 is presents a lot of opportunities for us on delivering on 21st century cures mandates. And so the draft trusted exchange framework getting to a final by the end of the year is a huge opportunity to take a very large step forward on interoperability and provide some good disruption to the market. I think the regulation we're working on around what is and isn't information blocking, actually, Congress defined what it is. We have to define what it isn't, which sort of ends up being the same thing at the end of the day, as well as some of the conditions of certification and getting the vendors on board with open APIs. That presents, I think, a really big opportunity that hopefully as we get into 2019, we'll start to realize some of the benefits of the things that we've done this year. But I mean, I think overall I'm very encouraged because it seems like the market, at least verbally, is saying interoperability is really good and we want to do it. I think it's going to be in the details of getting them to understand that interoperability is good, not just with the people I want to share with, but it's good when everyone is sharing with everyone, so that patients really do have access to their data no matter where they go for care.
Yes, sir. What?
Is there an idea on like a chart and a stick to get the big vendors to participate in open APIs?
So the conditions of certification requirement, we anticipate that, obviously our certification program is voluntary, but all the large vendors have done it and will probably continue to do it. So we think the condition of certification we're building out, which requires the open APIs, will get them on board with it. The only thing to keep in mind is that there is an implementation time frame, right? And so we always have to temper this a little bit with if the standards are available this year, it takes at least a year or more. I'll let Tom correct me if that's not right, about a year or more to build that into your product. And then it's a rollout phase to your end users, right? Because unless you're a cloud vendor where you can just roll it out all at the same time, most of the large vendors are not. And so that means every health system has to also roll out and implement those APIs. And when you're talking about open APIs, it isn't just a vendor decision. The health system has to actually turn on that open API and say, yes, I'm going to give you access to it. And so the vendors can do everything right. And if we get health systems who still just don't want to turn it on, we still have a problem. And so we're certainly working very closely with our colleagues within CMS around how we make sure that whole picture works.
Tom, maybe I'll ask an internal question if I'm allowed. Cybersecurity, of course, is very important to DoD. I'd be interested in the view of my colleagues on that. DoD has cybersecurity requirements, as you can imagine, that we have to adhere to. So from the end user standpoint, we're, of course, looking at things like system availability, latency, and things like that. But I've been interested in either of your views on that cybersecurity piece when it comes to interoperability. Maybe Genevieve.
Vitally important. Is the bottom line statement. So security is hugely important. We're talking about trust framework. A big part of that is having trust that I'm sharing the data in a secure manner. So in the framework itself, we actually build in a number of security requirements. We set some levels for identity proofing and authentication, which right now are highly variable. There's some health systems and networks where it's like a Facebook level of identification, which means they didn't identity proof you at all, right? Like you just signed up for an account and they believe that you are who you say you are. And then other folks are like crazy the other way, level 4 on the NIST scale, you have to present in person and that is the only way you get access. So we took a pass at setting policies that are reasonable, hopefully, but like maintain security of the system. But it honestly just requires constant vigilance because the smarter we get with security standards, the smarter hackers get with what they do. And obviously things like the Equifax breach are really problematic for authentication and identity proofing in particular. if you talk to the NIST folks, if your data was in the Equifax breach, the current NIST level 2 identity proofing and authentication, if that's what you're using, any one of us can get hacked, right? Like that's just at the end of the day where we're at. And so I think we have to figure out smarter ways to do it, but stay on top of it.
It's a really interesting question. I was actually thinking about this the other day because, on one hand, if VA-DoD has a single instance or host our data centrally, we will likely basically adopt the DoD cybersecurity policies, which, many of you probably know are much more stringent than what's used on the outside. And that's a good thing and a bad thing in many ways. And we have to have this discussion through governance for what's accepted and not accepted, right? Well, what are we going to be okay with? And for me, I'm not so concerned about the healthcare community, the hospitals, the providers sending us data. It's a lot of these apps that are coming in. We're not going to be able to accept that data because they just don't meet the security standards. So I think all of you folks here in the room will start getting office visits because the VA can't work with some of those app developers or companies because they can't share data with us. And so I think we need to start having a discussion on what's acceptable and not acceptable. I feel like if IRS can find a way to keep our data, and maybe we can find a path forward.
Then, for context, apps themselves are not HIPAA-covered entities or business associates. They fall outside of the realm of HIPAA. Flip side of that is patients under HIPAA have the right to walk into any provider office with any app of their choosing and say, get my health data to it. That is a guaranteed right under HIPAA, and it's very important. So I think some of it is ensuring that we don't have paternalistic attitudes that say, well, I don't trust the app that you walked in with, because frankly, if patients want to use an app that isn't a wise choice, that is still their choice, right, at the end of the day. But making sure that we have appropriate security in place so that at least I'm identity proofing to a level that I at least know it's the patient asking for the data via the app and not someone else, and that it's not able to come into my system and get access to my data, which, by the way, every technical person I've talked to said that the FHIR APIs that are read-only, there is no concern that an app developer could reverse engineer that into a system. And so I think health systems are just as concerned as the VA about this, but some of that is they're concerned about the perception from the public of what could happen versus what the reality of their liability is.
Well, this has been an incredible conversation, and I want to ask you to join me in thanking each of our panelists for participating today. Dr. Paul Cordts, Dr. Ashwini, and Ms. Genevieve Morris. I think we've started out the year right on this interoperability discussion, both at a DoD, VA, and then national level, and I look forward to more interactions with you through the HIMSS Institute for eHealth Policy. Thank you to all of you for coming today, and look forward to future discussions. Thank you.